Good evening. Can you all hear me?
Good evening. Yes,
Doctor, Professor. Thank you very much.
Yes.
I'm Lalit Pallegam, Chairman of Civil Engineering
Good evening.
Committee of this year.
Can we hear?
First, I would like to invite you all to switch off your mic and cameras. Then the disturbance will be minimized. With that, first of all, I would like to welcome you all for this lecture. This lecture is organized by Civil Engineering Section and Committee. Especially, we have a subcommittee for organizing lectures. Unfortunately, we are organizing this year only online lectures. Actually, this is a very important lecture because normally we organize many civil engineering engineering subjects, but today our committee has decided to go for another very important subject. So then I would like to welcome our resource person today, Professor Sunit Agampodi. Professor, can you hear all of us?
Yes, I can hear.
Yeah, I will go for. Thank you very much, Professor. I will go for a small description about Professor because the topic is COVID-19 virus variants, epidemiology, risk, and testings. This is a very important subject. I am not going to go in the topics because we have very good resource persons today. Professor Sunit has obtained his Bachelor of Medicine, Bachelor of Surgery degree from Faculty of Medicine, University of Peradeniya. Further, he completed his postgraduate Doctor of Medicine, specialized in community medicine from the Postgraduate Institute of Medicine, University of Colombo. Then Masters in Public Health, specializing in Epidemiology from Massey University, New Zealand, and Master of Science. Then Postgraduate Institute of Medicine, University of Colombo. Currently, he is serving as a professor and department chair, Community Medicine, Faculty of Medicine and Allied Science, Rajarata University of Sri Lanka. With this international engagement, he is currently working as a visiting research scientist for School of Medicine, Yale University, USA also. We know we all are in a little bit trouble in our country, so this knowledge is very important because he's giving his much service to the country as a member of independent review expert panel for COVID-19 Sri Lanka. With that small introduction, I would like to welcome a professor to start the this important lecture. Actually, I must say there's a knowledge sharing event. And one important note is you may not given any opportunity to ask question, but if you have any question, you can type. Then we will forward to professor. Then he will answer the questions at latter part of the lecture. Over to you, professor.
Thank you very much. And can you all hear me?
Yeah, professor.
Yes.
First of all, I would like to thank the Institution of Engineers Sri Lanka for having this, giving this opportunity to me to share some of the things that we are talking about in relation to COVID-19 pandemic and SARS-CoV-2 virus infection. As a public health physician, I think this is a really good opportunity because controlling COVID-19 pandemic is beyond the medical care and the field of medicine. It's a public health issue and it's a social issue and it's a global issue where everyone has a role to play, and especially professionals in all categories. So I think the engineers also has a very crucial role to play in COVID-19 pandemic control as well as pandemic response. So I will be talking about a little bit about virus variants, but that part will be only to describe because it was a request made to describe about different virus variants, and then we will talk about global and local epidemiology, not about the theories, concepts, but we will look at the national data available in different angles and to interpret this data to get an understanding on where we are and how the pandemic is progressing. I'm going to share my screen. Can you also see the presentation now?
Yeah, Professor, we can see.
All right. So we will be talking about COVID-19 virus variants, mainly epidemiology, and then a little bit about risk and testing. To start with about the different virus variants, I'm sure that most of you have heard about the different names they are using. As an example, we are talking about UK variant in Sri Lanka right now, and then about South African variant, which seems to be having some of resistance, or some studies show that there might be in, vac vaccine effectiveness issues. And then our neighbor India is having a current outbreak with Indian variant, and then we are using different numbers like B1415, B16174, and then for Sri Lankan variant, we have B1411. So all these names, I'm sure that most of you have heard, and I'm sure some of you have uh, read about these variants also. But we will see what these variants are and how these variants are, uh, how the classification are done. Uh, Again, I'm sure that you all know that this virus, uh, SARS-CoV-2, severe acute respiratory syndrome, uh, coronavirus 2, it's a virus. Now we say it's SARS-CoV-2 because we had SARS-CoV-1 few years back, and we also had a small pandemic. We can't even compare that pandemic to the current pandemic we are having. And this virus, they are having this, you can see these spikes around this virus. And most of the time, these virus spikes, they contain the antigen where our cells in our body can identify this virus through these spikes. And these spikes are, so we call these are antigens, and they have antigens, different antigens in these spike proteins. And the changes, different changes in these proteins can uh, are actually classified as different variants. So what happened is that every time this virus infect someone, so when it comes to our body, it start replicating, so it start reproducing. And the reproduction rate is very, very high, because not like us, they have a very short lifespan, and very rapidly they are multiplying. And each step of multiplying, when any organism is multiplying, including human, there might be very small changes in their genes. So one change in one nucleotide in a very small in the genes can call a mutation, is called a mutation. And this one change, one point mutation, it's called point mutation, can change the protein structure or the function of that particular protein. Now, as an example, let's say when we saw this SARS-CoV-2 virus for the first time, the way it behaved is completely different from what we see right now. So they have to have a special protein to bind to our cells and then get into our cells. So after some time, after we first detected this one, we have seen that specific protein which binds to our cell has changed, slightly changed, so that it can bind more perfectly, or it can bind perfectly to our cells so that it can easily get into our cells. So like that, there will be mutations when it is spreading. So large scale spread is actually facilitating these changes, genomic changes and mutations. So with that, there will be different virus variants. So if you see how the viruses are changing now around the globe, we are using this Pango lineage classification system for these virus variants. It started with A, and then it goes on dividing, and there are things called clades, virus different strains. When it is different particular uh, up to some extent, we call it a different clade. And then you can see first it's A, and then there are different variants in A. And you can see now this one line, when there are small mutations, small differences, it goes on this line saying this, let's say A1, A1.1, A1.2, A1.3, like that. So then we have B variants, C, B1, B1.1, C. So it goes like this. So this is the hierarchical system. So this reflects virus evolution history. So if it is C, we know that it evolved so much from the first one we have seen. So that's from A. Now, when we first identified Sri Lankan SARS-CoV-2 virus, now Sri Javardhanapura University, Professor Nilika and their group, they are doing this whole genome sequencing of these viruses. And so far they have done 238 sequencing. Now, this is the first part of our pandemic before March. During that period, they have identified mainly this B1411 lineage. So this is, we had this one, and then there were several other countries, of course, Europe and USA, those, all these types they have detected there. And so in few countries, we have seen this so-called Sri Lankan lineage, and it's from the main clade B. And if you look at the early studies on this B1411, all over the country. So during this is the so-called first and second wave. I will come to that because actually we can't say it's the first wave or second wave due to the that uh, outbreak we have seen. It's not really a wave, but still during that period, March 2020 to March 2021, during that 1 year period, this is how they have done the whole genome sequencing of this virus, and every place they have identified different types of this same variant. Then in March 2020, they first reported that they have identified this so-called UK variant. But again, during that time period, it was not the UK variant predominant in Sri Lanka. But in April 3rd week, they have done several sequences and sequencing, and then they identified that this UK variant or B117 variant is predominant in Sri Lanka. And this particular variant was having higher mortality rate, higher morbidity rate, and higher transmission rates than the variant we are having. And this was the main variant they had in UK, and then all around the Europe. And then we have observed that this particular variant, UK variant, all around the globe, causing morbidity and mortality in every country it was uh, identified. So far, as of today, Sri Lanka has done a whole genome sequencing of 79 of this UK variant B117, and it's the predominant viral variant we are having, and and that's why we are seeing this current surge of cases, especially due to this particular variant. Now, since there were country names attached to these variants, so for people were using this always with as UK variants, South African variant, Brazil variants, Indian variants. But then WHO had a discussion because it was attached to countries and country names, and also Pango lineage is having uh, different numbers which are not easy to use. They have done a recent different classification to identify these viral virus variants in a different way, and it is based on transmissibility of the virus virulence of the virus, clinical disease presentation, and whether it is there are detrimental changes in the epidemiology, and also whether there's a decreased effectiveness in public health measures or social measures or available diagnostics, vaccines, or therapeutics. When they are having these issues, if it is highly transmissible, virulent, and causing a high level of complications or deaths, then these are categorized as SARS-CoV-2 variants of concern. So they say VOC. These variants of concerns, we have four main strains: alpha, beta, gamma, and delta, because these are the variants which are causing the highest level of morbidity and mortality around the world. Now, as I uh, mentioned during the earlier slide, the UK variant is the most widespread one, but now we see the Indian variant within last 2-3 weeks. The Indian variant, that is Delta, is coming up everywhere in the world. Even in UK now, the predominant infection is due to this Delta variant. And then we have Gamma, that is previously Brazil variant, or Pangolin P1 variant. It was causing huge amount of deaths and cases in Brazil, but we haven't seen we haven't seen global other countries. I mean, globally, of course, not widespread. Now, one or two words about this alpha and delta variants. Now, the most recent reports, now even in Sri Lanka, there were one or two Delta variant. And then I'm sure some of you have heard about what is happening in Thailand, Singapore, and uh, even UK, and most recently Australia, that Indian variant with very high virulence and transmissibility. These cases due to this particular variant is increasing. And of course, the most recent news in Australia, they have identified one of these Delta variant from Australia from a person who came from Sri Lanka. So that particular person, Sri Lankan person, had Delta variant. He was not an Indian. He was a Sri Lankan. So the problem is that since he was not detected as having symptoms or suspected as having uh, close contacts with uh, people in Sri Lanka with infection, before he went there, because he was diagnosed as having COVID-19 as soon as he landed. So the first PCR. So by the time he left Sri Lanka, he was having the disease. The problem is that by that time he could have given it to several others. And now we are a little worried because Delta may take over Beta, uh, Alpha in Sri Lanka. And then again, we might see another surge because there are slight differences in transmissibility and virulence and clinical disease, very slight differences. So other viruses, other variants, so they are called variants of interest, VOI, because they are not causing uh, very high level of disease all around the world, but there are different other variants like USA, Brazil, this epsilon, zeta, eta, so there are different names given. Now, all these variants are also causing uh, common transmission, and there are multiple clusters reported and in multiple countries, but not as the four alpha, beta, gamma, and delta variants I mentioned previously. So one of the more question always we ask or people ask is, with these virus variants, with the mutations, what will happen to the vaccines available? Now we know even in Sri Lanka, we are using three types of vaccine: AstraZeneca, Sputnik, and then Sinopharm vaccine. In US, UK, Europe, and other countries, they are using more than that, including Moderna, Pfizer, and other types of vaccine. The problem is, the question is whether these viruses, whether these mutations, new variants, will there be new variants which are not uh, effective, which are not, which are actually resistance to these vaccines, and whether the vaccines are not effective against these viruses. So far, what we have seen is that all the variants we see around the world, they are still, all the vaccines are effective against these virus variants. But we have seen different level of effectiveness. Now, as an example, the effectiveness of all these vaccines against the South African variant seems to be slightly less than other variants. So there's a threat, there's a problem where the new variants might come up and vaccine may not effective. And as we all know, in microbiology or in medicine, we always say that the battle between microbes and human always, microbes always wins, except very rare occasions, and they are far ahead of us when we think about this battle, because whenever they come up with whenever we come up with something, they change their genome, they come up with a new variant, and then they can survive. So we will come to the epidemiology of COVID-19. And now this particular part, I'm sure that most of you have heard, and some of you may be monitoring, some of you may be involved in modeling of COVID-19, because the term epidemiology and epidemiological modeling are not basically for medical doctors. It involves a lot of mathematical modeling component where sometimes someone from your field are, or may be involved in these epidemiological uh, explanations. Just to give you a summary, if you can't remember what is happening right now around the world, by today, 8th June 2021, we have 3.7 million deaths around the world due to COVID-19 and 173 million confirmed cases. And these two, if you think about uh, deaths and cases, the actual estimate, these are the reported numbers, 3.7 million deaths. The estimate is about double. It's around more than 7 million deaths. So the total number of estimate deaths is actually 7 million. If you think about it, it's about 1/3 of our population, Sri Lankan population. And again, total confirmed cases, it's again the same. So it's about 300 million or more than 300 million. We suspect that they have been uh, infected, and still the transmission is going on. And new deaths and new cases, yesterday we had about more than 7,000 reported new deaths and more than 300,000 new cases reported. This is the global figure. And if you look at the pandemic or epidemic curve of this pandemic starting from March 2020, March 1st, 2020, you can see there were two large peaks. And so this particular peak, first large peak, was basically due to the peak in UK and USA. The majority of cases are from USA, and there were contribution from Brazil, Peru, and these Latin American countries. And then the second peak, the peak we have seen last 2 months. So this is more than half of it is from India. And even though we see reducing numbers when you look at the global situation, these numbers, these reducing numbers are basically due to reducing numbers in India. And we all know that there are issues in testing, there are issues in uh, proper identification of cases. So it's not really reducing. And now we see new clusters appearing in other countries. And especially with the Indian variant, that is Delta, appearing in other countries, we expect that there will be another surge, or it may change the direction. Even though it goes down with the reduction of Indian cases, there may be small surges, or there might be some other variants coming up. So based on the previous pandemic experience, usually uh, the global pandemic, this type of global pandemic had at least three main peaks, and that's why we are worried, because we have seen the first part, we don't see it as a peak, but we have seen two main peaks. What is happening in Sri Lanka right now? Again, if you look at one thing I want to explain, this is basically theoretical, and for the sake of explaining some of the epidemiology, the reason I mentioned that for the first, when I started, that this is not the third wave. Now you can see when you look at this graph, this is the first real wave we are observing in Sri Lanka. The first part, this March 2020 to around August, even though we say that's the first peak, there was no peak at all. So we had a small number of cases, sporadic cases reporting mainly from Western province for about 7 months. And we can't say it's a peak. And then we had one large outbreak. Again, there was a peak, but it's basically due to one cluster. So we had this Kandakadu cluster where we had large number of cases in a well-defined population. The majority of the cases are from that particular community. So they were well in one place, and those who got the infection from them, the numbers were limited. The way they kept in that particular place, it was very easy to trace the contact and then quarantine them and then control the disease. So it was, rather than it was a wave in Sri Lanka, it was a one small outbreak, one small cluster. Same thing happens with the Navy cluster, where they had large number of cases within Navy. Again, it's in one camp, and then from that particular camp, there were infections spreading to other camps. Still, it's within a well-defined cluster, and then their families and probably some of their neighbors and friends. Again, that part also, the contact tracing was done properly, and it was easy to do the contact tracing, isolation, testing, and treatment. Then we had a large sustained cluster after the Paliaguda and Brandix incidents. Again, Brandix, so that clustering of cases in Brandix and then later in surrounding areas and their families, it is not as well defined as the Kandakadu cluster, but still it was in a one place, basically in one place, and it was possible to trace contacts at least at the neighborhood level, and then do the isolation and contact tracing up to some extent, but not as previous to. And then we had one, while the Brandix cluster is going on, we had Paliagoda cluster. Now the Paliagoda cluster is different than the previous clusters we have observed. It was not in a well-defined place, even though we say it's a Paliagoda cluster. There were a lot of contamination, a lot of spread all around the country. And then we have started, after Paliaguda cluster, we have started detecting cases, random cases in different districts in the country without having a clear link to Paliaguda cluster. And that's why after that, we have a large, not as much as we see right now, but for about 2-3 months, we had large number of cases, more than 100, around 100 and 200 cases going on in January and February. But again, there was a slight increase, but uh, this is not a real peak happening in,
හරි මුකින්
which was happening in Sri Lanka. It was related to Paliaguda cluster, but we might
අපේ
say,
අපේ එක වීඩියෝ එක පෙන්වන්න යාළුවා. සවුන්ඩ් එක විතරයි එන්නේ.
uh, so can you all see the presentation, PowerPoint?
Yeah, because we can see, but there's a small complaint about sound. Is there any possibility to increase increase your volume?
Yeah, sure.
But
The,
I can manage. I can hear, but this is
Is
yeah,
it
yeah,
okay
yeah.
now?
So, Professor,
yes.
Yeah.
it's a kind request. It is better to unmute all do not allow their unmute the mic, because so most of them may be in the mute unmute condition. So then the sounds will be distorted. I send a message to Mr. Pallegam also. So it is better to
Yeah, Mr. Raj.
not to allow
Yeah, I
themselves to
think.
unmute. That is that may be the
Thanks,
reason.
Mr. Raj.
Please
Okay,
keep
we'll go.
the mic muted except your host and host. Okay.
Yeah, we'll go ahead. Thanks,
All
Mr.
right.
Raj. Okay.
All right. So, sorry about that. So I was describing the epidemiology, the epidemic curve of current COVID-19. Now, after April second week, we have clearly seen a peak or a wave happening all around the country. Maybe some cases are concentrated in some of the district, but this is all around the country, and it's a huge peak. And this is the type of wave we see in a real pandemic. This is what they have observed in other countries, and this is what we are going to discuss today. Discuss in the next slide, because the previous part actually we have seen what is happening, and there were a lot of discussion about that part. And looking at the whole epidemic curve will not allow us to explain what has happened over last 2 months. So if you look at the so this is called epicurve or epidemiological curve. And if you look at starting from 15th April, what has happened from 15th April, we had a small number of cases. So it's about less than 200. We had the cases slightly increasing from 15th to 17th, 18th, 19th. And then we saw that a definite increase starting from 15th, and it was going up. And actually by 19th and 20th, the epidemiologists, we had a discussion observing that this increase is unusual, and we have seen more hospital admissions, more ICU requirements, and more patients requiring oxygen. This is where by 19th April and 20th April, we had first had our concern, and it was obvious the way the pandemic was going, and we predicted that there will be a surge of cases in Sri Lanka, not only based on the numbers, but based on the human behaviors as well. Because we all know what has happened prior to the festival, the way people do shopping, and then the behavior during the Urdu period. With all this background, we predicted that there's going to be a huge surge of cases within next 2-3 weeks. As predicted, the cases started rising, and by 25th April, the number of cases, we have seen more than 5 times increase of cases within 10 days from 15th to 25th. And then 25th to 5th, around 5th May, then again cases doubled from 1,000 to 2,000. Right. So even though we have seen a plateau starting from 1st May to 7th May here, about 6-7 days, usually the epidemiological pattern should be, it should be increasing number of cases. So it can happen, things like this can happen in any country. So we suspect that some of the cases are missing here due to some reasons, we don't know. But there was a gradual increase of cases. And then it went on increasing, and by 19th May we had more than 3,500 cases, and from that day up to now, still we are getting having cases from 2,500 to 3,500 varying numbers. So there are different reasons. I will explain how we see this reducing cases, then again increasing, and all these things. These are very common in pandemic situations in any country, but still we are in this wave. And even though we see some reduction of cases here, again we will see increase of cases here, so it will go on like that. I want you to again pay attention on this one, because these are some few things that we are actually not looking at when we look at the news or other websites. Now this graph shows two different things. So it shows total deaths in Sri Lanka and total cases of Sri Lanka. Now, these numbers may be slightly different, because even if you look at the different websites, government websites, there are slightly different numbers. It can happen because of the time they report and all these things. But if you look at the pattern, not the numbers. So this blue graph, blue line, it shows total cases. And so numbers relevant to this blue line is in right hand side. You can see numbers are exceeding now 200,000, and the yellow line is showing total deaths. And what I want you to look at is, starting from 21st of April, the way these lines are behaving, there's a difference. So the total number of cases is increasing. Total number of deaths are also increasing, cumulative number, but total number of deaths, you can see it crosses now the direction. You can't say crossing the line, because these are two different numbers, two different scales, but you can see the direction is different. And the number of deaths the increase of number of deaths is higher than the increase of number of cases. So that means even with the same numbers reporting, we are getting more deaths. Or the other explanation is that we are not seeing the actual numbers. So numbers should be going like this. So we missed some of the cases due to the limitations. We will come to that later. And when we say we see increase of deaths, again, this increase of deaths, now we might not see the increase of deaths, because the way we are reporting, it's not like cases. Now, when we say today we had 2,000 cases identified, PCR positive, again for cases also, even though we say we identified 2,000 or 2,500 cases today, the actual patients, when the samples were not collected today. So samples collected yesterday, day before yesterday, or it may be up to 4 or 5 days based on the situation. All these samples collected are tested during a day, and then when we are reporting, we say the number of samples positive today, but it doesn't mean that these are active cases, people who were detected as having COVID-19 today, but they were actually diagnosed probably maybe even 4 or 5 days back. Same thing happens with death. Now that particular is the particular now case identification is due to the reason that we are having limited resources. Now this is common to many of the countries, not only in Sri Lanka. Because when you are having limited resources, now we are doing around 20,000 to 25,000 PCR per day. It's not a small number, it's a huge number. But when you're having this capacity, when you come to this capacity, beyond that, it's very difficult to do. So that you will see a backlog and accumulation of samples, and that's why we are having this problem. Now, when you go to deaths, if you listen to a news, they might say we had 3 deaths reported today, and then there were 10 deaths yesterday, 9 deaths the day before, like that. Now, as an example, if we look at 21st of May, when they are reporting deaths on that particular day, there were 3 deaths from that particular day, but other deaths were here. Now, we will take example here. Let's say the death reporting on 26th May. So they say there were 2 deaths today, and then 6 deaths yesterday, 7 deaths day before that, and then total number of this much. But what will happen, even though there are numbers showing very small number of deaths. I mean, on 21st, it was only 3 deaths. But when you go on adding these things, starting from 20th to 7th June, so all these are available in government website, government information website. You can see there were 53 deaths on 21st. So this happens because when you have a death, you have to do the death investigation, you have to order inquest, and then to do a postmortem. Once you do the postmortem, you have to provide the report. It should go to the national level. So once you do all those things, and when you report all those things, sometimes it takes time. And if there's a weekend, it can delay. So things like that, because of things like that, there's a delay in death reporting. And you can see all these numbers in government websites and on daily basis. So what you see on daily basis about deaths is actually not what is happening on that particular day. So when we are interpreting numbers, you can't say when someone says that today we had only 5 deaths or today we had only 28 deaths, we don't know actually what is happening. Tomorrow it might say that yesterday we had another 21 deaths. And then about deaths, you see these numbers in most of the time in media. They are showing these numbers. Most of the deaths occur in, let's say, 50 to 60 age group or 61 to 70 age group. This is again based on the published data from different government websites. These are not actual exact numbers. There may be slight differences in these numbers because numbers were taken from different websites. Uh, let's say uh, about 130 deaths in 50 to 60 age group and 230 in 60 to 70 age group. So when you look at the numbers, you might say there are large number of deaths in 60 to 70 age group, about twice. So it's not double actually, but we can say twice the number of deaths. But the problem here, if you really want to identify the real issue behind these numbers are deceptive. And in epidemiology, we always say the counts doesn't say anything about what is going on. If you want to look at these numbers, you want to see what is the actual population in this category. Because we know the numbers are different. The denominator is different in these numbers. So if you look at the actual population who are aging 31 to 40, 40 to 50, 50 to 60, and divide this number, you will get the death rate. So when you look at the death rate, you will see huge differences, not like this, in death rates. Now, as an example, 50 to 60 age group, and if you compare this 50 to 60 age group with 70 to 80 age group, the difference. So they are having 6 times high death rate compared to this group. And it is not shown here. If you compare it with 30 to 40 and more than 60, 24 and 230, it's almost, now here it's about 10 times 30 to 40 and 60 to 70. Here, 30 to 47 and 670, 141, this is 20 times high. So actual risk of these elderly people having is not shown in these numbers, but you have to look at the rates. So what is actually happening in this is that death rates due to COVID-19 in elderly population in Sri Lanka is huge compared to other age groups. So they are having a very high risk. So since we are talking about risk, if you think about risk for deaths, not for uh, getting the disease or disease transmission, if you think about death risk, it's increasing exponentially with age. It's a huge increase. Then another indicator to look at the what is happening in Sri Lanka right now, you can see starting from April 1st or 2nd or 3rd week, when we look at the death case fatality rate. So case fatality rate is the number of deaths among number of confirmed cases. Again, remember this may not be the exact numbers because the number of cases and number of deaths. For the calculation of case fatality rate, I got from the published data. So the published data is not actually showing but deaths and cases on particular day, but we assume that when you smoothen it, the, this line might show the trend. So until the second week of May, case fatality rate was less than 1 in Sri Lanka. And then we have seen it goes up and more than 1.5. And you can see now it's remaining in from 1 to 1.5, this range. So the next question we always ask is, what is the risk now and what should be our response and how could we prevent this type of outbreak? The pandemic response, even though we are not discussing it now, the flattening the curve, 1 year back, everybody in Sri Lanka, almost everybody was discussing about flattening the curve. So what do you mean by flattening the curve is that when you have a pandemic, and if you allow pandemic to continue without a proper response, it will go up, and in some stages, it will exceed the healthcare capacity. So what do you mean by exceeding the healthcare capacity? After these numbers go up to certain level, we will have all our beds full with COVID-19 patient, all our ICU beds full with our COVID-19 patient. Any additional patient will not get the proper treatment, and any additional patient who is requiring ICU care will not receive ICU care. And if there are patients who require ICU care but still in wards, they are going to die. So we can't prevent that. So by doing all these interventions, by flattening the curve, what we are trying to do is to keep it under control so that when they come to hospital, we have enough hospital beds, we have ICU beds so that we can prevent deaths. But by flattening the curve, the cumulative numbers may not be much different from what is actually happening during the original curve, this red curve here. So what we have seen in Sri Lanka during this third wave, now we are having this movement restrictions. Actually, there was a little delay. Even before movement restriction, we observed that our healthcare capacity was exceeding. There were no ICU beds and patients were at home. It was difficult to remove patients to ICCs. And then, so after some time, the movement restrictions were in place. And after that, there was a change in the direction of epidemic curve. And this is what actually we wanted to do. So just by having, now when we had our control measures, the strict control measures somewhere here, it takes times to, change the direction. Even after changing the direction, we are still somewhere here where we can see increasing number of cases. So it will take time. It will take few more weeks. If we are to maintain this level of movement restriction and precautions, then after few weeks only we will see cases going down and coming to this the limits of healthcare services where we can manage it properly. But then again, there will be few months to control the pandemic. So with movement restriction, or shall we say lockdown, even though we are not using the term, with lockdown, we are not expecting to commit, change the direction of the epic curve completely and see reduction of deaths and numbers. No, it was not the intention. So our intention was to make it under control so that we have a space. The healthcare system will have a space to get ready, get prepared, and then people will not die once they come to the hospital. Then about testing, few words about testing. We all know that if you listen to media and if you read newspapers, there are a lot of discussion going on about testing. What we do is mainly PCR, then we have RAT or rapid antigen test, and we talk about random testing. I'm sure some of you have heard about ILI or SARI surveillance, and then screening for symptomatic patients. There are a lot of things going on. Even now, Sri Lanka is using PCR or polymerase chain reaction as the main method of screening. But in other countries, actually, PCR is now replaced by, most of the PCR are replaced by rapid test, rapid and cheap test. There are tests available, but still those tests are not available in Sri Lanka. I think there are processes going on. Even one Sri Lanka test produced in Sri Lanka will come to market within next few weeks. And then we have rapid antigen test. The problem here is, as a resource limited country, now as a lower middle income country, we will not be having the number of tests we require now. And it is not possible and it is not rational to go on increasing PCR test because it is not the way to control a pandemic. If we are having limited number of tests, what we should do is a proper allocation of test or changing the testing strategy. So random testing should be done for the risk identification. Now, random testing is not done for patient identification, because patient identification, if you are doing random testing, it's not going to be helpful. It is for the purpose of identification of risk. Then we have something called influenza-like illness surveillance. It is happening only in hospital outpatient departments. This is to see what is happening, or what is the number of patients who are having mild respiratory illnesses, flu-like illnesses, and having COVID-19. Again, this is a screening process where we are trying to identify how it is going on in the community. And then, of course, we have symptomatic patients, patients who are having COVID-19 like symptoms. We have to do screening for these patients. Now, allocation of PCR rapid antigen test, we have to do it in a proper manner so that we have all three of these. So there are some other categories as well, is functioning properly, and these numbers, the proportion of people who are positive in random sample, ILI surveillance and screening will provide valuable information on the pandemic direction and what to do next. So this test, this is what has happened in this test positivity. Again, these numbers, as the same reason I mentioned, the numbers are different because the test we see and the positivity is different in different days. But if you look at the trend, you can see starting from 3% in April, test positivity has come up to 14 to 16% now. This means if you test 100 people right now, 14 to 15 people will get positive results. In other words, now we are testing about 20,000 people per day. So what will happen if we test 40,000 people? So it might, the numbers, the positive numbers will go up definitely. It may not go up to from 3,000 to 6,000. It might not be doubled, but definitely it will exceed 5,000 or 4,500 or 5,000. So if we go on increasing the testing, we will see more and more cases. So the cases, whatever the numbers we see right now, is completely limited by the number of tests we are doing, and it is a well-known process in any country, not only in Sri Lanka. We have to understand that as well. So if we are to look at, if you combine all these things, now again, these axes are different, so you can't compare directly. We have to look at only the trend of these things. Now, if you look at this red line, this is PCR, number of PCR done. You can see it goes up like this, and then it reached our maximum capacity somewhere in uh, April, actually April, and then May second week. After that, our PCR capacity, it remains around 2000. So we have a limit here, PCR, number of PCR doing. It has increased up to 15th May, and then it decreases, and now it's a plateau. These are the number of tests we are doing. And with that, you can see number of new cases are also increasing. But the number of new cases, you can see, irrespective of the number of PCR, the numbers are slightly different here. You can see it was due to higher test positivity. Even though PCR numbers were reducing, the number of positive cases were still high. And test positivity rate is like this. You can see more than the number of PCR we have done. The test positivity rate provide more realistic picture about the number of new cases. If we had, let's say now PCR in 13 to 19, the same number these days, we will definitely see higher number of cases. And if we can double, the numbers will go up. Now, what we should understand is with this one, what we really need is reallocation or redistribution of PCR, having a different strategy so that we will detect all the cases, but not wasting our limited resources on all suspected and all quarantine patients. So that type of, I think, that part is going on right now in health ministry. They are looking at these issues we are having right now, limitations, and trying to uh, change the test strategy. So within the 1 hour time, because this more than 1 hour discussing about any topic is will be boring, but these are few things I want to discuss with this community so that you will have a better understanding. When the media provide you with some information, you can see the information, the numbers are different from what is actually happening, and you have to interpret those numbers in a different way, thinking about capacity, our response, and what is happening in Sri Lanka and what is happening in other countries. Thank you very much.
Thank you, Professor Sunit Gampodi. It was a very clear and very well planned lecture. Actually, myself even learned a lot. Actually, I learned a lot, definitely. Very clear and very well, I think, actual facts. So, if any member want to ask question, we can allow few times, few minutes. And Professor, can you see the question and in the chat box? So do I need to read it? The few questions only last.
I will look at the question in chat. All right. So the first question is, I think, this viral WhatsApp consequences of vaccine over the natural selection, and that viral WhatsApp message was later declared as a fake one, actually. So now we have seen what is happening with vaccines. Now there are a lot of diseases we don't see right now. Now, as an example, we don't see smallpox. We don't even see measles. Very few of you have seen measles, polio. So vaccine we have been using for very many years, and some of these concerns, and there are well organized anti-vaxxer groups. So some of these stories and myths are by them, and as a fact we know it's a fake, and it was proven to be a fake, that viral WhatsApp video. And then the other question is whether these viruses may be having mutations going on mutation for a long period, and human race will be having a threat. Uh, so we have seen there are documented pandemics over many centuries, including the same influenza pandemic, and then plague, malaria, cholera, different pandemics. And some of the pandemics were actually wiping out about one-fifth of the human population and one-third of Europe population. But usually, in when the microbes are having mutations, and usually what will happen is after 2 3 years, if it is a pandemic, the mutations is such that they will be having a coexistence with their host, so that they can survive. So we don't there are no facts, so there are no scientific proven facts to say that there's a threat for the existence of a human race. And then there's a question about what is the best vaccine. Uh, the best vaccine is the vaccine available for you. Why I say this? Because now all the vaccines we have right now in Sri Lanka are having very high level of effectiveness. And as an example, the vaccine we are having right now, Sinopharm, it has almost 100% protection, almost 100% protection after the second dose against death, not viral transmission. And then very high effectiveness against severe disease. And still with the vaccine, you might get the disease, but you will not get severe disease. You might not need ICU admission. Definitely, you will not uh, get a fatal infection with vaccine. So Sinopharm, Sputnik, AstraZeneca, all three vaccines we are having right now have a very high level of effectiveness against death, more than 80% effectiveness, almost 90%. Again, disease, getting the disease, but still you can get the disease, but with very mild symptoms. So whatever the vaccines available, if you can have access to vaccine, my advice is don't even ask, go there and get the vaccine. Then you will be protecting yourself, your family members, and your community members. Most suitable age for vaccine, again, remember, now we are not recommending this vaccine for children because of one reason, because the vaccine was not tested, or the clinical trials have not included children. Now the same thing happens with pregnant mothers and lactating mothers. When AstraZeneca came to Sri Lanka, the health minister guidelines said that it is contraindicated. People who are women who are pregnant and lactating should not get AstraZeneca vaccine. But the reason behind that was because there were no clinical trial done, including pregnant mothers. But even by that time, UK, USA, and many other countries, they have already given this vaccine to pregnant women. And by now, there are large number of vaccines given to pregnant women, and we know that there's no risk. And if you look at the theoretical background behind vaccine development, there's no way of getting some adverse effect other than the fever and the usual adverse effect, which is due to not due to it is not a side effect actually. It is expected because you are exposing your body to a antigen, or antibodies are producing in your body, so you might get this fever and other issues. But for children and pregnant mothers now it is recommended, but even for children, they have not done clinical trials yet. But for Pfizer vaccine, which I think we have already ordered, the health ministry had ordered that Pfizer vaccine is recommended for children and it is using in USA. And once we get the Pfizer vaccine, I'm sure that health ministry will start giving it to children. Okay, this is very common question about traditional Chinese medicine together with Western treatment now, and whether we are having a proper approach to include our Ayurveda medicine. first thing I should say is that one thing I can say is that I have my knowledge only on Western medicine, so therefore I can't say whether the Ayurvedic medicine is working or not. If I say it's not working, it's not scientific because I have not studied that. But China, not only for COVID, for all the other conditions, they have a system, integrated health system where they use this traditional medicine. Even though in Sri Lanka we are not having an integrated system, I'm sure that everybody is using traditional medicine now. If we are having a fever or a mild flu-like symptoms, everybody is using coriander, and I'm sure we are using many other things. But the problem is that whether it is effective for COVID or not, we don't know. Unless we do proper clinical trials, we can't be sure of that. So if we can't be sure of that, we can't say whether it is working or not. Now, there are a lot of claims saying that there are about 100 patients who had this drug, and almost everybody, or let's say 99 of them, uh, they they got cured because of this particular drug. But if you look at the numbers, 2 months back, everybody who got infected, only one or two died. Everybody got cured, even without any drug. So just by looking at those numbers, we can't say anything. And whether any of these things are working or not, I can't comment on that. But there's a way of proving that before we recommend. What will happen if we are doing that, if we are not proving it and recommending it, people might think that this will work, and then once they get it, or once they decide that they have access to this drug, they will behave differently, and it will trigger another wave, or it will increase the transmission of disease. That is the threat we are facing. That is the threat we had during last few months. So about the drugs for COVID-19 infection, again, uh, first I should say I'm a public health physician and an epidemiologist. I'm not a specialist in clinical management of COVID-19, but as for right now, we don't have a medicine, proper medicine to say that this particular medicine will cure these patients. There's none. There are some drugs which are showing slight, higher level of recovery, but none of these things are uh, working properly. I know that even in Sri Lanka, there was a big mafia about a particular drug saying that this is working, but we don't have enough evidence to say that those drugs are working. So about lab leak theory again, there are a lot of theories, a lot of conspiracy theories about the virus. Unfortunately, I can't comment on that because there are a lot of rumors going on, but there are no substantial evidence to say that those things are true. So the one question is, as usual, whether we will have three main global waves, uh, and the question is whether we will this time also we will be having one. Whether we are going to have another wave or not, we have to live with this pandemic at least for another 6 months. That is the minimum. Probably another 8 months or 12 months. But with the increased vaccine production, I think that we will have, not only Sri Lanka, other countries will have access to vaccine, because as long as other countries are having the pandemic, even if we get the vaccine, we'll be still having the problem. And that's what has happened to UK, USA, Australia, and many other countries. So uh, be prepared. We are going to have this at least for 6 months, or at least probably, let's say, next new year we'll be having the pandemic. So we will not be able to come to the normal life we had 2019, at least for next 6 or 8 months. Now, worldometer data and the global reduction of cases, yes, I agree that look at the numbers, it's reducing, but it doesn't mean that this pandemic is going to be end within next month or two. Whether the people who are infected with COVID-19 vaccine receive the vaccine, yes, it's very clearly mentioned. Now, people who are having immune-related condition, and if they are on suppression drugs, then of course they are having a problem about receiving the vaccine. That is, the those people should be separately assessed by the treating physician, and only after that they can get the vaccine. All the other people who are having hypertension, diabetes, CKD, chronic kidney disease, actually they should get the vaccine before all the other people, because they are having very high risk of death. How to differentiate between common cold and COVID-19? There are specific symptoms, but the problem is that what we see is about 60 to 70% of people, they are not having the symptoms, and it will be very difficult to decide whether it is common cold or flu if it is mild COVID-19. So the best thing is to do, if you're having a fever, if you're having, even if you think that this is common cold, all the family members had this, please try your best to isolate yourself for 14 days, even if you are not having any COVID symptoms. That is the best thing you can do, and that's the way to protect your family members. And if you are having access to uh, testing, so go there and get a test done, and only after that you can say it's not COVID-19. Even after a test, if it is very early testing, you might get negative results. I can see a lot of questions coming up. And there's a question about climate condition and spreading of COVID. No, actually, so that was the earlier theory that people were saying that we are in tropical countries and we will not get the disease because only Europe and USA is having that. But later we have seen first in Brazil, Peru, and Latin American countries, South American countries, then in India, and now in Sri Lanka. So all the climate conditions, they are getting the disease in the same way. So the booster dose, actually, different vaccines are having different time intervals for the booster dose based on the immediate immune response. So based on the vaccine you are going to get, it may be different. And please remember, within the pandemic, the vaccine development was so rapid and vaccines are still evolving. So even though, let's say we ask now, when AstraZeneca came to Sri Lanka, we said the booster dose should be given in after 1 month. But after some time, there was a new paper coming out, and then it said that it should be given after 12 weeks. So like that, there might be changes in this vaccine and vaccine recommendation. It is expected. So it's not a problem. It is expected because still we are dealing with this pandemic, and the pandemic, the usual vaccine development process takes years, about 3, 4, 6 years to take place. So here it's a rapid development, so therefore even the knowledge on vaccine and what will happen with vaccine is still fresh and it is changing. uh, Even if you get the vaccine without knowing positive, it's not going to be an issue. So there's about, again, another question about Ayurvedic drugs. The question here is, actually it says Ayurvedic Council has recommended more than 10 medicines for COVID-19. Actually, it is a wrong interpretation. They have not recommended any of these things as drugs. What has happened was they have almost all these preparations were approved as food supplement, and by that condition only, I think you should be able to realize that those were approved as food supplements, not specific treatment for COVID-19. So Ayurveda Council, they have approved it under different uh, category. And I don't think that, I'm not telling that these drugs are not working. What I say is that I don't know about that unless there are evidence or proof to say that these drugs are actually working. What is the probability of developing a vaccine in Sri Lanka? The first problem is that the basic facilities and infrastructure we are having in Sri Lanka, because by the time the COVID-19 first viral genome of COVID-19 published, the labs around the globe which were in the vaccine development process for many years, they were ready to develop a new vaccine. Now, if you look at the laboratory facilities for biomedical research in Sri Lanka, still we don't have a single lab to do that type of vaccine development. And even now, I think only now we are trying to produce vaccine which are already developed in Sri Lanka, Sputnik vaccine. They are trying to do it, but the problem is still now we have to set up the infrastructure entirely and then do that. Even after that, we have to have people who are trained in that process. Unfortunately, there are Sri Lankan who are in in this process who are heavily involved in vaccine development process, but none of them are in Sri Lanka. All of them are in other countries because they don't have enough work to do in Sri Lanka, so that they are not coming back here. What we should do is, it may not be this pandemic, but if we can start right now, if we can develop this biomedical infrastructure for vaccine development and drug development, at least now, so someone might say it's the lasting legacy of COVID-19. So we will be able to do that for other pandemics and for other diseases we are dealing with right now. And I fully agree that at least now we have to think about those things and then have the infrastructure here in Sri Lanka to do vaccine development and then drug development. Again, the question about positive results due to rapid antigen. So what is happening right now is all the rapid antigen test positive, they are undergoing PCR and before they are declared as having COVID-19. But in other countries, actually, most of the countries, they have given up doing PCR. If they are asymptomatic and rapid antigen positive, they can straight away go for isolation or home quarantine and 14 days. And they're actually not repeating PCR. CDC, they have recommended, specially recommended, and it is evidence-based recommendation. What they say is in their guideline, if there's a person who is asymptomatic but PCR positive, you can isolate that person for a particular time period. What their recommendation is 10 days or maximum 14 days. But after that, you don't have to test him again because PCR may be positive even after that period. And also it's a waste of resources. But in Sri Lanka, we are still doing that. I think there might be changes. I hope there will be changes in this strategy because we have to do PCR. We have to change the policy and do PCR for symptomatic patients rather than people who are not having any symptoms and having already PCR positive and having 14 days quarantine. We actually don't need PCR for them. So there's a question about COVID-19 prediction model for Sri Lanka. There were several models developed for Sri Lanka, and one of the model developed by actually there were about 4 published models, but most of these models are not available online. The models available at global level, they are not considering the Sri Lankan specific variables. There's only one model with the public access where you can change the parameters based on Sri Lankan experience. It was developed by 3 Sri Lankans, including myself and Savitru. And so these 2 young guys from MIT and Harvard University, it's available. I will actually share that link with the association institution so that you all can play with it. It's anyone can play with it and then see what is going to happen. And that particular prediction model prediction is pretty accurate. We have done prediction during this third wave. We have done prediction about cases and numbers, they are actually pretty accurate. So there's a question about PCR negative and antibody positive. What does it mean? So PCR negative and antibody positive means that you have antibodies against COVID-19 in your body. That means you had a previous infection. Even though you are not having the infection right now, you had previous infection. The question about whether the COVID-19 vaccine or COVID vaccine, any vaccine available at private sector in Sri Lanka, again, that's a policy decision. Uh, I don't know whether there's a discussion going on. What I know is that sometimes back there were some requests, but the vaccine production is still low, and still they are not having, they are not giving, at least some companies are not giving it to the private sector, but I'm unable to give you a proper answer because I don't know at policy level what is the discussion going on.
Professor, shall we, because question is coming, I think
Yes,
this is
I
not.
think there will be question if we there for another few hours, there will be questions.
Yeah. Yeah. So, because this is a very good event, the very first question you missed, I maybe not purposely. That question was introduce a guideline on how to COVID related news reported. Actually, I also feel the same thing when I listen your lecture, presentation. It was very clear and very with facts, and that is very important. That is the important part I heard. So
Yes.
I am planning to suggest to our ISL to release uh, the- this as a link for all members. Then all members can then at least one community of the in our countries know the actual facts. So we'd like to thank for your effort. That was a very great effort. And I would like to thank our subcommittee, especially Engineer Sanjay, who coordinate you, and other review team leader. And I would like to thank ISL as well. And finally, I would like to thank especially Professor for this very factful lecture. And normally, if you have these type of lectures in our auditorium, then you will receive some kind of token of appreciation, but unfortunately there's no way to give, but we would like to give that token of appreciation by our all heart to stay safe and do this very valuable and very important service to the country, and to this kind of thing. And hopefully we will contact you again and to get more knowledge. And meantime, if any member have any clarification, they can contact us and we can send to you if any important matter. So with that, Professor, do you need anything to tell to our members?
One last thing, I would like to thank the organization for organizing that, because I feel that one of the most important thing we need during this pandemic is to get proper data and proper information so that we are not interpreting it in a different way. It's very bad for pandemic response. And at the same time, I would like to request you all as a leading professional organization and professionals who are listening to this, please encourage others to read carefully, interpret carefully the facts, because the media most of the time they are providing facts but without knowing. It's not they are not doing, I don't think they are doing it purposefully, but without knowing the epidemiological or public health background in those facts. So listen carefully and use your common sense before interpreting facts. It will help us to as a country to control this pandemic. Thank you.
Thank you, Professor, and thanks for all listeners. And we will meet again at this kind of lecture. And stay safe and good night. Thank you very much to all.
Good night.